Good.
Awesome.
Okay, so I was just going to talk about Charcot Arthropathy. I had a patient recently in my clinic, and that kind of piqued my interest. Next slide. So Charcot Arthropathy, people refer to it as Charcot Foot or just Charcot. It also can be referred to as neuropathic arthropathy, diabetic neuropathic arthropathy, or diabetic osteoarthropathy. It's not Charcot-Marie Tooth disease. It's a separate disease. That's an inherited disorder causing nerve damage, and can also called hereditary motor and sensory neuropathy. So it's completely separate. Next slide. So Charcot arthropathy is a progressive musculoskeletal disorder, can be characterized by bony destruction, bone resorption, and eventual deformity due to the loss of sensation. It becomes a concern for us in the clinic, especially with our diabetic patients, because it can result in pathologic fractures, ulcerations or infections, loss of function, debilitating deformities, and possibly amputations. Next slide. If we leave it untreated, again, this kind of reiterates that last slide, it becomes a progressive cycle of destruction in bone and soft tissues at the weight-bearing joints. And most patients I've seen in clinic have it in the foot and ankle. Any disease that causes a sensory or autonomic neuropathy can actually lead to Charcot arthropathy, but diabetes is the current leading cause. Next slide. So it's multifactorial due to a combination of mechanical and vascular factors resulting from diabetic peripheral and autonomic neuropathy, as well as metabolic abnormalities of the bone. And as people step or their proprioception, where they feel their foot is in place, there's a lack of that proprioception, which can be from peripheral neuropathy and can result in patients having a laxity in their ligaments, an increase in range of movement, instability, and damage by minor trauma. And then this becomes, important in patients who have insensitivity to the neuropathic foot. The changes in the architecture of the foot, and it can also cause a change in weight bearing and subsequent localized traumas. Next slide. So in the diabetic patient, they've got some neuropathy and vasculopathy, and again, metabolic abnormalities of the bone. Some sort of trauma usually causes an inflammation, and then the bone gets resorbed. That can lead to another deformity of the bone, but also if they develop stress fractures from different traumas, also a deformity. And then their weight bearing becomes abnormal, which can then lead to ulceration and infections. Next slide. Studies show varying degrees of incidences. I found anywhere from 0.12 to 12%. I think the higher percent is probably from those specialty clinics who see oftentimes the more severe cases of diabetes. But type 1, they're usually found in their 5th decades with the average sugar duration of 24 months plus or minus 8 years, while type 2s tend to present in their 6th decade with a mean duration of 13 plus or minus 8 years. One of the VA studies did show that obesity had an increased risk for the Charcot arthropathy. Next slide. So bilateral involvement in less than 10% of our patients. Recurrence is in less than 5% of patients. We do know that people with Charcot have a higher risk of amputation. Diabetes with Charcot is at about 7 times the risk, and patients with an active ulcer with diabetes and Charcot have about a 12 times increased risk of amputation. Next slide. Causes, again, diabetes is the primary cause, but it also can be from other forms of neuropathy listed there. Next slide. The clinical staging is stage 0, which is your early or inflammatory state, where there's localized swelling, erythema, and warmth with little or no radiological abnormalities. And this can occur with even just the minorest trauma. Stage 1 is the developmental phase, where they actually get the swelling, the redness, the warmth still persists, but then they start developing bony changes. They could have fractures, subluxation, or dislocation, and bony debris are apparent on the plain radiographs. And this is where my patient actually presented. He had had a history of just this foot that was swollen and sort of deformed. And when you looked at it, it looked like a Charcot foot. And I'll show you some slides here in a bit. But leading up to that point, he had already been on steroid from his primary care, as well as some antibiotics, which really didn't relieve the issue. And then he had been scheduled with podiatrist, but I had seen him prior to that new patient visit with podiatry. So stage 2 is the coalescence phase. It's where clinical signs of inflammation have decreased and radiological signs show either a fracture healing, resorption of bony debris, and new bone formation. And then stage 3 is the remodeling phase, where they are the redness, warmth, and swelling has completely resolved, and bony deformities are there either stable or unstable. And the radiographs may actually show mature fracture callus and a decreased sclerosis. Next slide. So most frequently, as I stated before, metatarsophalangeal joints and the ankle. 75% of the patients have pain. They have mild to severe swelling depending on the stage that they're in. They also can have the erythema as discussed. And sometimes even the temperature of their skin can be elevated. Next slide. So in initial evaluation, you actually want to confirm they have peripheral neuropathy. And I also try to look every time I see a diabetic, just take a peek at their feet, because you want to look for portals of entry for infection. If they've got ulcerations or even deep ulcers that probes the bone, this may be concerning for osteomyelitis. So in your differential, you may be looking for other things, but sometimes that will include a CBC and dip, renal function, and then just other tests that you're trying to exclude, maybe a culture, maybe a synovial fluid assessment, seborrheic or CRP. Honestly, unless they look infected, most times I'm not doing all these tests. I usually, if it's been to the point where they're like stage 1, 2, or 3, sometimes I'll just get the x-ray and kind of see what that looks like. And by that time, they're usually already referred to podiatry. Some of the imaging, you can just do plain radiographs. If this is normal or inconclusive and you're still concerned, then they recommend doing a non-contrast CT. You can do contrast. It might provide additional information, but as long as it's safe for the patient, depending on renal function and hardware and things like that. And then bone scan is also another alternative to MRI, but I think most people sort of start with the MRI. Next slide. In the early acute disease process, this is kind of reiterating one of my other slides. That first one is sort of the same thing. Later stages, though, you may see resorption findings in the forefoot. Can lead to osteolysis of the phalanges, a variety of further changes, including partial or complete disappearance of the metatarsal heads. They call that pencil pointing. You can see fragmentation, sclerosis, new bone formation, subluxation, sometimes dislocation. And again, stress fractures might be a little difficult to diagnose and may be better located on an MRI or a nuke scan rather than the normal x-ray. Next slide. So your index of suspicion should be pretty early in the diagnosis stage. You want to make sure you're looking and thinking about your diabetics who may have just unilateral warmth, swelling, or redness of the foot, particularly in the context of having peripheral neuropathy and long-standing diabetes. Sometimes we mistaken it for cellulitis. I think this is what my patient had. The primary was trying to treat it like a cellulitis. Osteomyelitis is in the differential, septic arthritis, gout, inflammatory arthritis, complex regional pain syndromes also can present similarly. Next slide. So this I've seen many times. This is what we call a rocker bottom foot. You can actually see the arch in the foot has been collapsed. And then this point of area where the arrow is pointing, they have a bony formation, and sometimes they get calluses in those areas. It's not a normal area of pressure, and so that does increase risk for skin breakdown. Next slide. Another patient, this patient didn't really have any, warmth, any skin changes, but as you can see, probably a side view would be better, but You can see a little bit of collapse of the arch, and there's some swelling on the examination. Next slide. This is a plain radiograph of the foot. It shows some typical neuropathic joint disease involving the tarsometatarsal joint spaces where the arrows are. There's destruction of the joints, adjacent bones. It kind of looks like a big mess in there, to be honest. But that is something typical you might find on a radiograph. Next slide. This is also very common, in my clinic. I usually ask the patients, if their foot had changed over the years, but you can see the loss of arch there on the foot. Next slide. So what you want to consider when you're treating these patients, of course, their comorbidities, their balance and mobility, and risk for falls. And sometimes we do get other disciplines involved, including rheumatology, podiatry, physical therapy, sometimes rehab, PT, and sometimes in cases, orthopedic surgery. So the early stages, we definitely want to offload these feet because we want to reduce pressure, especially if they've got fractures. We don't want to create more problems. I don't, usually the podiatrist will prescribe the footwear, and they'll measure the foot and send the paperwork to me, and we can get that signed by the physician. Sometimes referring to orthopedics is, something you need to do in these difficult cases. In reading, I did find some recommend anti-resorptive therapy like bisphosphonates, but there's some uncertainty with the efficacy, and we definitely want to avoid these agents in patients with CKD. But it's really as an adjunct to offloading. Next slide. So immobilization is to prevent further destruction. You could either use total non-weight bearing or partial weight bearing with assistive devices. Sometimes, until we continue that until the redness and swelling go away and the skin gets improved. And it's a long time. Actually, the duration is variable, but it can be 9 to 25 months in non-removable casts and 3 to 36 months in removable casting. And of course, if you have the ones that aren't removable, they should be seeing their podiatrist regularly to get that cast removed every couple of weeks to allow for a decrease in the swelling. Next slide. And these are just some examples of things that they can use in patients. I'm not typically ordering these devices. By this point, they're usually seeing a podiatrist or an orthopedic surgeon who's managing this. But, it can be challenging. You have to be really careful in knowing those patients and checking their feet every visit to make certain they're not developing new sores or wounds, and basically trying to preserve them from getting preserve function enough and prevent them from getting, developing at a point where they need amputation. That's all I got.
Thank you. That was wonderful. We do have time for questions. I actually had one and now I need to remember it. As their diabetes improves, does this seem to go away at all, or is it really something that just needs referred out at that point?
So usually it's a permanent damage of the foot or ankle or the joint that they're affected in, so the deformity usually persists. There can be some improvement, of course, of like the swelling, the skin temperature changes, but in my experience, once they've had some radiographical changes, those persist, and it's an ongoing thing where they need to be monitored regularly with podiatry and as well as the provider who sees them for the diabetes. But the good things can improve and the infections can go away, of course, but usually the physical changes in the joint and bone don't go away.
Yeah. Yeah. Does anybody else have any other questions about this or anything else you'd like to talk about?
I joined in the midway. Okay. Now, when we know the patient has Charcot foot, okay, do they automatically qualify for this kind of shoes or supportive thing? I'm not talking about the regular diabetic shoes. I'm talking about more like a orthotic device that takes off the weight, do they automatically qualify even if they don't have any ulcer or anything?
Sorry, I'm not understanding your question. It's breaking up a little bit.
So Dr. Pollywall is asking if they would automatically be allowed to get an orthopedic shoe or something if they don't present with an ulcer or something like that to help with all of the problems they're having.
Usually, if the forms that they require from getting those devices, they have to have, usually a foot deformity will get them, coverage for that. The other thing that can get them coverage is pre-ulcerative calluses with peripheral neuropathy. So, just plain old neuropathy usually doesn't get them a foot orthotic, but when you see those forms, I always make sure I put in my note. Neuropathy and even if it's a callus that's, it's not breaking open, it's no fissures, I usually document it as pre-ulcerative callus because they're all pre-ulcerative. They're callus, they're a change in the skin. So typically that will get you coverage. The other thing will be evidence of vascular disease. That should get you coverage, but it's on the form that they have filled out. So I usually try to get anything I can. But at that point, when they've got Charcot, they're usually seeing either a podiatry or orthopedist where it's well documented. So it shouldn't be a problem once they have the deformity.
Thank you. All right, guys. I really appreciate everybody's time. I know that was a quick session, but if you guys have any questions, I'm always here. I will be sending out the slides so you can read through them. And if you do have any questions, I'll make sure Renee gets those. And I'll give you guys the session for today, of course, on the YouTube link. I do want to let you guys know we aren't going to be having the normal session on October 9th, which I think is the next one. I'm kind of running out of days at this point. But the hub, the Endo Echo Hub, will be meeting and we'll be kind of discussing what's going to be coming up in 2020. So if you guys have any topics you want to hear about, any questions you want us to discuss, please let me know and I'll get those on the calendar.
Okay, thank you.
All right, thank you. That was great.
Thank you for your time.
Thank you.